Welcome back. I'm an emergency doctor actively working at the emergency department of my hospital. In this Doctor's Corner series, we'll dive into lesser-known approaches and hidden strategies to help the people with critical illnesses. You can subscribe if you want to learn the latest news and healthy solutions about your health. Good day, everyone. Today, focus on one idea. Do not try to force sleep. Build a system that makes sleep more likely. Tell yourself this clearly. My goal is not to command my brain to sleep. My goal is to train my brain to feel safe, timed, and ready for sleep. Why is that distinction so important? Because sleep is not a muscle you can simply flex. You cannot order your nervous system, sleep now, and expect obedience. In fact, the harder many people try to sleep, the more awake they become. Why? Because effort creates monitoring. Monitoring creates tension. Tension activates the brain. Then the bed slowly becomes a place of calculation. How many hours are left? What if I fail again? How will I function tomorrow? That is how insomnia quietly turns the bedroom into a performance room. So, do this instead. Set goals around the behaviors that prepare sleep, not around sleep itself. This is not just motivational advice, it fits closely with the strongest behavioral treatment model we have for chronic insomnia, cognitive behavioral therapy for insomnia, or CBTI. The American Academy of Sleep Medicine gives CBTI a strong recommendation for adults with chronic insomnia, and it describes CBTI as a combination of sleep regulation education, cognitive strategies, stimulus control, and sleep restriction therapy. The American College of Physicians also recommends CBTI as the initial treatment for chronic insomnia in adults before routine medication use. The 2023 European Insomnia Guidelines similarly recommends CBTI as first-line treatment for adults of any age, including those with comorbidities. Now ask yourself, if the leading medical guidelines keep pointing toward behavioral treatment, what does goal setting add? Here is the answer. Goal setting turns treatment principles into daily actions. It converts I should sleep better into I will wake at 7 o'clock, leave the bed if I am stuck awake, stop clock checking, and review my sleep diary every morning. That shift is small, but it can change the entire architecture of the night. Start with the first command. Stop making sleep your only target. Why? Because sleep is partly automatic. It depends on circadian rhythm, homeostatic sleep pressure, emotional arousal, learned associations, light exposure, caffeine timing, and the meaning your brain attaches to the bed. If your goal is simply, I must sleep 8 hours tonight, you have chosen a goal that is not fully under voluntary control. And when a goal is not under voluntary control, failure becomes personal. The person begins to think, something is wrong with me. That thought raises arousal, and arousal feeds insomnia. So set a controllable goal. Say this, tonight I will protect the conditions for sleep. How? Begin with measurement. Keep a sleep diary for 7 days. Do not make it complicated. Record bedtime, estimated time to fall asleep, awakenings, final wake time, rising time, naps, caffeine, alcohol, exercise, and medication if relevant. Why measure? Because insomnia often lives inside distorted perception. When people are exhausted, the brain remembers the worst parts of the night with high intensity. A diary gives you a calmer witness. AASM guidance has long emphasized that sleep diary data should be collected before and during active treatment, and behavioral insomnia care often uses diary information to tailor prescriptions such as stimulus control and sleep restriction. Now give yourself the second command. Make goals behavioral, not emotional. Do not set the goal, I will feel relaxed. Feelings fluctuate. Set the goal. At 10:30, I will dim lights, put the phone outside arm's reach, and begin a 20-minute wind down. Do not set the goal, I will not worry. Set the goal, if worries appear, I will write them on paper and schedule them for tomorrow at 4 p.m. Do not set the goal, I will fall asleep quickly. Set the goal, I will enter bed only when sleepy, not just when it is late. Why does this work? Because insomnia is often maintained by a loop. Wakefulness in bed creates anxiety. Anxiety teaches the brain that the bed is a threat zone. The next night, the body enters the same room already alert. Goal setting breaks that loop by assigning the bed one job again: sleep. That is the logic behind stimulus control. Go to bed when sleepy. Use the bed for sleep and intimacy only. If you are unable to sleep after a reasonable period, leave the bed, do something quiet and low light, then return when sleepy. Repeat calmly. Do not punish yourself. Train the association. Ask yourself, how does a bed become a cue for wakefulness? By spending hours in it awake, frustrated, scrolling, planning, negotiating, and fearing tomorrow. Now ask the better question. How can the bed become a cue for sleep again? By making the pattern consistent enough that the nervous system relearns the signal. ASM's guideline supports CBTI most strongly and also gives conditional support to components such as stimulus control, sleep restriction therapy, and relaxation therapy as treatment options for chronic insomnia. Now move to the third command: set a fixed wake time. Why wake time, not bedtime? Because wake time is an anchor. It tells the circadian clock when the day begins. If you sleep poorly and then sleep in for hours, you may reduce sleep pressure for the next night. Then the next night becomes harder and the cycle continues. So choose a wake time you can maintain most days. Protect it. Get out of bed. Seek morning light. Start the day even if the night was imperfect. Do not be harsh. Be consistent. There is a difference. Harshness says, I failed. Consistency says, I am training a rhythm. Now use the fourth command, write if-then goals. Why? Because vague intentions collapse at night. At 11:45 p.m, the tired brain does not want philosophy, it wants a script. Behavioral psychology calls these implementation intentions, specific plans that connect a cue with an action, such as, if situation Y happens, then I will do behavior Z. A meta-analysis by Gollwitzer and Sheeran found that implementation intentions had a medium to large positive effect on goal attainment, and sleep-focused studies have examined these if-then plans for sleep hygiene, sleep duration, and bedtime procrastination. So write them down. Do it today. Say, if it is 9:30 p.m, then I will begin closing the day. If I pick up my phone in bed, then I will place it across the room. If I am awake and irritated, then I will leave the bed and read something quiet under dim light. If I think tomorrow is ruined, then I will answer, one poor night is uncomfortable, not dangerous. If I wake at 3 a.m, then I will stop checking the clock. Why are these plans powerful? Because they remove negotiation. They reduce the number of decisions you must make while tired. And in insomnia, decision fatigue matters. The night brain is not always wise. Give it instructions before the night begins. Now set the fifth command. Separate the sleep goal from the life goal. Many people with insomnia make sleep the center of their identity. They cancel plans, avoid exercise, dread the evening, and spend the day scanning their symptoms. Understand this carefully. Insomnia is real and it can be deeply disabling. But if life becomes organized entirely around fear of the next night, the nervous system receives a constant message. Sleep is dangerous. Night is dangerous. My body cannot be trusted. So ask, what is the larger goal? Maybe the larger goal is to function with more steadiness. Maybe it is to return to morning walks. Maybe it is to reduce dependence on emergency coping. Maybe it is to rebuild confidence in the body. Sleep goals should serve life goals, not replace them. Say this, I am not just chasing sleep, I am rebuilding rhythm. Now learn the quiet paradox. Sometimes the best sleep goal is not sleep more tonight. Sometimes it is spend less time awake in bed. That may sound counterintuitive, but it is central to sleep restriction therapy. In this approach, time in bed is adjusted closer to actual sleep time to increase sleep pressure and improve sleep efficiency, then gradually expanded as sleep becomes more consolidated. This should be done carefully, especially in people with bipolar disorder, seizure disorders, severe daytime sleepiness, high-risk jobs, pregnancy, or complex medical conditions. Get clinical guidance when risk is present. Why does reducing time in bed sometimes help? Because the body builds sleep pressure during wakefulness. If a person lies in bed for 9 hours but sleeps 5 broken hours, the bed contains 4 hours of wake training. A carefully designed sleep window aims to make the bed a stronger sleep signal again. The goal is not deprivation for its own sake. The goal is consolidation, confidence, and retraining. Now create a weekly goal review. Do not review every hour. Do not judge every night like a final exam. Review once per week. Ask these questions. What did I do that helped my rhythm? What made the night harder? Was my wake time stable? Did I use the bed as a sleep cue or as a worry station? What is one adjustment for the next 7 days? Keep the goals small enough to perform. If your plan requires a complete personality change, rewrite it. Make it executable. For example, do not say, I will have perfect sleep hygiene. Say, I will stop caffeine after noon for 7 days. Do not say, I will become calm at night. Say, I will practice 5 minutes of slow breathing before entering bed. Do not say, I will never nap. Say, if I nap, I will keep it brief and early, unless my clinician advises otherwise. Now address medications with balance. Do not shame medication. Do not glorify it either. Medications may be appropriate in selected situations, particularly short-term or when CBTI alone is insufficient. But major guidelines place CBTI first because it targets the mechanisms that keep insomnia going. Conditioned arousal, maladaptive sleep behaviors, distorted sleep beliefs, and irregular scheduling. Goal setting supports that by making those mechanisms visible and actionable. Here is another question. Why do people often know what to do but still fail to do it? Because knowledge is not the same as execution. A person may know that scrolling in bed worsens sleep, but at midnight the phone becomes comfort, distraction, and anesthesia. A person may know that a regular wake time helps, but after a bad night the bed feels like rescue. This is exactly where goal setting becomes treatment support. It puts the right action in place before the vulnerable moment arrives. So tonight, do not wait for motivation. Motivation is unreliable at bedtime. Use design. Place the phone away from the bed. Prepare tomorrow's clothes before the wind down. Write worries before you enter the bedroom. Dim the environment. Set the wake alarm. Decide what you will do if you cannot sleep. Then let the goal become simple. Follow the plan gently. Notice the word gently. This matters. People with insomnia often become aggressive with themselves. They turn every technique into another pressure. I must relax perfectly. I must follow the rule perfectly. I must fix this tonight. That intensity can become another form of arousal. So command yourself with steadiness, not cruelty. Say, I will practice the plan. I will not measure my worth by tonight's sleep. I will repeat the pattern long enough for my brain to learn. Let us bring this together. Insomnia is not only a night issue, it is a rhythm issue, a learning issue, a conditioning issue, and often an arousal issue. That is why goal setting can be so beneficial. It takes a frightening, vague experience, I cannot sleep, and breaks it into controllable behaviors: wake time, light, bed use, wind down routine, if-then plans, diary review, and response to wakefulness. Why is this effective? Because it changes the target. You stop wrestling with sleep directly and start shaping the environment, timing, and habits that invite sleep. You stop treating each night like a crisis and begin treating it like training. You stop asking, how do I force sleep? And start asking, how do I make wakefulness less rewarding, less frightening, and less attached to my bed? So begin tonight. Choose one wake time. Write 3 if-then plans. Keep 1 sleep diary. Protect 1 wind-down routine. Review after 7 days. And if insomnia is chronic, severe, worsening, linked to depression, trauma, breathing, pauses, restless legs, medication changes, or unsafe daytime sleepiness, seek medical care. Do not carry it alone. The goal is not to be heroic. The goal is to recover wisely. Sleep is not conquered by panic. It is invited by rhythm, safety, repetition, and trust. Take care of yourselves, take care of each other, and let's keep learning as one family. I'll see you in the next topic.